Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center here in Fort Myers, Florida. We're actually, Danielle, today not going to talk about necks. We're going to talk about chest pain and the sternoclavicular joint. Specifically, it connects the clavicle to the sternum. So it's the main connector between the upper extremity and the body here. And basically, it's not a stable joint, right?
No, it's really like if you can look, like you've got your collarbone, your clavicle here kind of just setting in this groove of your sternum, and then it's just held together by ligaments. There's not really any bony stability there in that joint.
And often we say that joint instability is a progressive disorder.
Yeah.
So if you have shoulder instability and you don't do anything about it, one of the shoulder joints is the acromioclavicular joint here. So if you don't do anything about it, eventually that joint's going to get loose. So how would somebody know whether they have sternoclavicular instability?
Well, most of the time you can actually feel it click and grind and pop. So if you just even put your hand like right here where you can feel like it kind of protrudes, and then I tell patients, I'm like, just do like a chicken wing maneuver, like where they just kind of keep bringing their arm up and down like that. Like you'll actually feel it kind of grind, click, and pop. You touched on this, what people may not realize is that this actually is considered part of your shoulder, technically speaking, even though it is at the front of your chest. But because your collarbone also comes over here and attaches at your AC joint, it really is like, can be this kind of like seesaw kind of dynamics where you're getting injury here and injury or overuse there.
The other thing too, I think we don't maybe appreciate enough is that this joint is actually very close to where the rib attaches, the first rib.
Yeah.
First rib problems are actually probably more common than people think.
I think so. Quite frankly, a lot of times these overlap. Sternoclavicular, even AC joint or other shoulder issues overlap with the first rib because the anatomy is just so close together. And if you're someone that you have a lot of overuse injuries from poor posture, or you like fell, on an outstretched hand kind of thing, a lot of times multiple structures get injured in the process. But people with first rib issues, a lot of times, like even if you just kind of press on their first rib, it's very, very tender. They'll get a lot of popping. Even if they like kind of like roll their shoulders in a way, it'll pop and click. They get a lot of tightness, like your scalene muscles that attach there. Everything is so tight. Those are other things that you'll see with the first rib issue.
No, you made a good point, because there's muscles like the scalene muscles that attach to the first rib, and the scalenes can basically compress some of the nerves in the neck. And then sometimes even MRIs, I've had MRIs document that the person had hypertrophy, like they had really, really big medial scalenes. And the question always is, if somebody ever got an MRI or they went to a physical therapist or massage therapist and they said, God, your scalenes or whatever are really thick or they're really tight, you have to think about, well, what could the scalenes be doing? So if the scalenes are tight, it's going to elevate your ribs. So maybe it's compensatory because you have rib instability.
Yeah, it's possible.
Now, why don't you go through the other joints, since we're in this area, like the other joints in the chest?
Yeah, so if you look at the chest, again, like the SCJ joint is really technically part of the shoulder, even though it is located in the chest. But you have all of these attachments as your ribs come around to join the sternum. So you have the connection between the sternum and cartilage, right? And so then you also have the connection between your cartilage and your actual rib. Okay, so you've got your costochondral joint and your sternocondral joints, and those actually are like the stabilizers of the front of your chest.
To protect your lungs and to protect your heart. And then I found too, when these are loose, the patients can feel like they have shortness of breath. Like I can't catch my breath. And then they can get gripping pain because if the rib moves too much, it's going to hit the intercostal nerve. So what intercostal neuralgia, what symptoms do you get with that?
A lot of that can be very painful. A lot of pain. It can mimic chest pain, as if someone might think that they're having a heart attack. The intercostal nerve kind of goes around like the entire, part of the rib. So people that have instability here, or even instability in the posterior part, if any rib at any of that point slides and touches on the nerve, it'll get this kind of wraparound pain on one side.
Yeah, real sharp pain.
Yeah.
Then if you have rib instability or thoraco-rib instability or sternal rib instability, you tend to be a very shallow breather. You know, because, you know, let's be honest, like we all know that to help your vagus nerves and to be calm, caring individuals, it's very helpful to deep breathe, you know, like belly breathe.
Yeah.
But when you belly breathe, you know, you move the ribs. So if you're somebody who's having trouble getting deep breaths, you got to think of, well, there might be a reason that it's so painful to take a deep breath, and that could be, you know, some of the instabilities we're talking about. Most slipping ribs are often here. So, and then we have the floating ribs, but see how there's what, 1, 2, 3, 4, 5 ribs go just to one area. So if you injure this area, the cartilage here, the junction here or here, it's going to affect like 4 or 5 ribs. And I think that's one of the reasons why most of the slipping ribs are actually very, very low. So what's the treatment? If somebody had sternal clavicular instability, acromioclavicular, sternal, costal, costochondral instability.
Yeah, if quite simply, if there's joint instability there from ligament laxity and ligament weakness, the treatment is prolotherapy to strengthen those ligaments.
Yeah, I was just thinking about some of these joints, especially the sternoclavicular joint. There was a Dr. Koch, one of the old timers.
Okay.
So when I was writing the sports book, I contacted some of the old timers because I think you can learn pearls of wisdom from the old timers. So he was one of the few doctors that used non-diluted proliferant, because you know when you do dextrose, like dextrose comes in 50%, but then you dilute it to 15%. When we use a sclera or some of the other proliferants, we're actually diluting it like tenfold.
Yeah.
So this is one particular area because it's just ligamentous support. Like it's not a ball and socket joint. There's so much force. Like every time you use your arm, it gets transmitted there. And most of the people that come in, it's so clicky. Click, 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 click. So this is one of the areas where we would use less diluted than we normally would, and we may actually see them once a week or once every 2 weeks. Then do you ever tape them? You know, a lot of people talk about rock tape or sports tape.
I love rock tape personally. I do think that when you are dealing with a rib instability, like you have to do some kind of bracing to help hold everything together. Because again, these areas are under so much stress every day just from simply breathing. You know, it's going to stretch it a little bit. So I like rock tape. Not everybody can tolerate it. Some people have a lot of allergies, you know, skin allergies, and then we might want to consider even just kind of more structured bracing. Yeah.
So again, really severe instabilities. Just to optimize healing, you actually got to keep hitting it.
I actually have a first rib, we're talking about the first rib, a first rib case now where we're treating it every single week because it's so unstable that we just are really trying really hard with aggressive proliferant to get it to stabilize.
And the reason why we use bracing in some instances is actually to reduce the number of prolotherapy visits. If you think about prolotherapy, all a prolotherapist can do is induce the ligaments to tighten and thicken. But that requires the right forces in between visits. So if there's too much force on it, you're actually going to tear or reduce the amount of proliferation that the prolotherapy is inducing.
So kind of with that, you know, patients ask a lot, you know, what should I do? What should I not be doing in between treatments, especially for something like this where chest, thoracic, you know, sternoclavicular instability where symptoms can be so bad. And the biggest thing is reducing the force absolutely in between treatments. Now, doesn't mean you're on your couch, you know, being a couch potato, but trying not to, kind of what I say is like if you think about prolotherapy as a slow-acting glue, try not to shear the glue away.
Yeah, that makes a lot of sense. So anyone who's had a blunt trauma in an area that then has residual pain, there's a very good chance it's going to be joint instability. Then what about patients would say, yeah, but all the scans were negative?
Well, especially after a blunt force, that's good. You know, you don't want someone to have a broken bone or things like that, a fractured rib. But we also have to remember that X-rays and MRIs are not good at showing ligaments, you know, unless the injury is so severe. So if your X-ray was normal and your MRI was normal, I mean, there are good things to say about that, but that doesn't mean that there's not a ligament injury present.
Yeah. I mean, I still do ultrasounds and but even the ultrasounds sometimes in this area
Yeah.
You just got to go on. There's clicking, popping, grinding, and like my chest doesn't click, pop, and grind, so it's not normal for stuff to click, pop, and grind. So if you have clicking, popping, grinding, and you got pain here, you got joint instability. That's how you make the diagnosis.